So welcome to the realm of the hot flash. This room should be nice and warm. So today I want to tell you a little bit about hormones, but before I do that I want to introduce myself a little bit so that you'll know that I do know something about what I'm talking about. I'm a professor of OBGYN at Loma. I've taught there for 40 years, and I was the chairman of the OBGYN department for a number of years before I retired. I'm a reproductive endocrinologist, which means that I've taken special training in one of the subspecialties of OBGYN, which is called reproductive endocrinology. That deals with hormones and in vitro fertilization and infertility and those sorts of things. So I would probably not be bragging if I said that I probably know more about hormones than anybody within 30 miles of where we're standing here. And I've taught that and practiced it for many years. I have nothing to declare, no conflicts of interest to disclose. I'm retired, I'm not selling anything, and so I'm going to tell you what I really think. So first of all, let's talk about the menopause and what it is. When you were in your mother's womb, you were given all of your eggs, and you never made any more eggs after that. And beginning at that time, actually, when you were halfway through the pregnancy, when you were in your mother's womb, you started losing eggs. And by the time you were born, you had lost 90% of your eggs. You had 5 or 6 million when you were in your mother's womb. By the time you were born, you had about 1 million left. By the time you got to puberty and had your first menstrual period, you'd lost another 700,000 and you had 300,000 left. By the time you were 21 years old, you'd lost another 200,000 and you had 100,000 left. By the time you're 35 or so, you'd lost another 70,000 and you had about 30,000 left. And by the time you get to menopause, they're pretty much all gone. Okay? Now, those eggs in the ovary are surrounded by some special little cells. And the unit is called a follicle, and that's what develops and releases the egg when you have your ovulation. And those cells around the egg are what manufacture estrogen and progesterone, the two female hormones. Now, estrogen is a very, very potent hormone. It's the most potent hormone of all, actually. And when it was isolated and purified in the 1920s, it took 80,000 sow ovaries. It was done in Chicago, where they have the meat packing plants. 80,000 sow ovaries to get a little pile of estrogen the size of my little fingernail. So there are no natural sources of estrogen. There are none. We can't get it from animals. The closest we can come is we can get large amounts of it from the urine of pregnant horses, and that's called Premarin. And that was first actually brought into the market and used in the 1940s. So the only truly natural source of estrogen is Premarin, believe it or not. Now, Premarin is not bioidentical. Bioidentical means that it's exactly chemically the same as what your ovaries make. Your ovaries are a little estrogen factory, and they manufacture estrogen, and they make real estrogen, estradiol and estrone. And if you're pregnant, the placenta makes estriol. Okay, those are the main hormones. And those hormones are all converted into each other. So if the ovary makes a molecule of estradiol, it can be converted to estrone somewhere. And if an ovary makes a molecule of estrone, it can be converted to estradiol. So if you take one or the other, or any combination of those, they all get mixed up and all get sorted out here and there in the body. So where do we get estrogen today when you take an estrogen pill? Well, if you take your Premarin, that came from the urine of a pregnant mare. And by the way, the animal that has the most female hormone of any animal in the world that I know of is the stallion, believe it or not. The stallion has more estrogen in his body than any other animal that we know. That's just a trivia question in case anybody ever asks you about that. So where we get estrogen today is we get it from synthesis in the laboratory or in a factory, and we use precursors that generally come from the Mexican yam, a sweet potato found in certain parts of Mexico, and the story of how that came to be discovered is very interesting. So you can take the precursor in the Mexican yam, it's called diosgenin, and then you can take that to a factory and you can stick on some things here and there on the molecule, and you can come up with estradiol. And so that's how estradiol is manufactured. And it doesn't matter whether you buy the estradiol in a pill that's manufactured by a big drug company, or whether you buy the estradiol from a compounding pharmacist that's mixed it up, it's still estradiol. And it's still, if it's real estradiol, it's exactly what the ovary made, but of course it was manufactured. So that's what I know about natural and unnatural and all that sort of stuff. Now, the big disadvantage of buying your estradiol from the compounding pharmacy is that the compounding pharmacy is not regulated when it comes to the potency of that medication. And so you might get one batch that has one potency, and then you buy another batch and it might have a different potency. So I can't conscientiously recommend to you that you buy your estradiol other than what's in a capsule or what's in a product that's made by a large pharmaceutical firm. And again, I don't have any great love for pharmaceutical firms, but they do serve a function, and I have no conflict of interest as far as that's concerned. So the other female hormone is called progesterone. And progesterone is manufactured only after ovulation. It's manufactured in the ovary, and it also is manufactured in large quantities in the placenta and during pregnancy. And it's the hormone of pregnancy. It's the hormone that makes it possible for the uterus to maintain a pregnancy and so forth. And progesterone is made the same way. It's actually made from the sweet potato, the Mexican yam, and it's actually a simpler molecule than estrogen. It takes less work to manufacture progesterone than it does to manufacture estrogen. And the same is true with progesterone when you buy it. The biggest problem with progesterone is that it's not, and estrogen both, is they're not really effective when you take them by mouth. They have to be micronized. They have to be broken down into little particles and put in the capsule that way, and then they may be absorbed by mouth. And the other problem with estrogen and progesterone by mouth is that that's really not the way the ovary does it. The ovary doesn't put out an estrogen and progesterone pill into the palm of your hand and then ask you to swallow it. The ovary releases the hormone directly into your bloodstream. The only way that you can mimic that to take the estrogen and progesterone is if you take it through your skin or through your vagina. Okay? So there are estrogen patches. I'll say a little bit more about estrogen patches. I believe the evidence suggests today that that is probably the ideal way to take estrogen, is with patches. It may have less risk of blood clots, less risk of strokes, and some other things to make it a little safer. So I think that estrogen patches make a lot of sense. Unfortunately, progesterone, we really don't have a good delivery system for progesterone through the skin. And progesterone creams and whatever that you put on your skin has quite a bit of variability in the amount that's absorbed, and you can't really trust those to do the job that progesterone needs to do for you as you take hormone therapy. I'll say more about that in a little bit. Now again, this talk, I'm completely unchoreographed. I'm just going as I see the whites of your eyes and whatever, and pretty soon I'll let you ask questions, and we'll use your questions as a way of introducing new topics. But I do want to set the stage a little bit. I want to also tell you another thing about estrogen, and that is about how much estrogen there is in your body at various times of your life. So if we look at a little child, a little girl, before puberty, her estrogen levels are right down here, just barely off the floor. Okay? When she begins to menstruate and has her regular menstrual cycles, her estrogen levels fluctuate every month. They go up and they go down, and they start almost that low, actually, and they come up maybe to here, and then they go back down to here at the end of the month. So that's the normal reproductive menstrual cycle level of estrogen, okay? A menopausal woman has an estrogen level that's not quite as low as the little girl, but almost, just a little bit above the floor. And interestingly enough, all I have to do to take away her hot flashes is raise the estrogen, not clear up here like it was during menstruation and during your cycles. All I have to do is raise it from here to about there. And that's enough to take away the hot flashes. Just a little bit. Way less than what your body had every month all those years. And by the way, the estrogen level in pregnancy, when you were pregnant, the estrogen level is about 75 feet above the roof of this building. Incredible amounts of estrogen. That's why we turn to the urine of the pregnant mare to get it, because there's a lot of it in there. Okay. So lots of estrogen. So it's been a mystery to us how it is that you could say that a woman could have estrogen levels like this and like that, and then after menopause, why is it so bad to raise her from here to here? Why is that so bad? Well, it turns out that it might be bad in some cases and it might not be bad in others. And that's where the rubber meets the road, and probably why you came to hear me at this talk. So now you know a little bit about menopause and the physiology that's involved and things like that. So I need to tell you just a couple more things first. You don't just go into menopause like this and all of a sudden you're fine and you go clunk, you're into menopause. You know that. You go through a period of we call the perimenopause. And that's really almost the most difficult time for a woman, really, than the menopause itself, because you're neither here nor there. You're not menstruating normally and not ovulating regularly. Some months you ovulate, some months you don't. Some months you bleed normally, some months you don't bleed, some months you bleed too much. And finally, after about 4 years of that, some months you have hot flashes and some months you don't. After about 4 years of that, then the ovary completely fails. Because the ovary doesn't fail all of a sudden. Remember, it's losing those eggs all the time. And if it's got a few left, it can still fire one off. And so women sometimes even get pregnant when they didn't think they would, 48, 49. Doesn't happen very often, but you probably have heard of people that do that and so on. So the average age of menopause in the United States right now is about 51. Which means that perimenopausal transition begins about 47 on the average in the United States. But there's quite a bit of variation. The normal variation is plus or minus about 4 years. So there are women who go to 55 and they're still menstruating, and there are women who have menopause back at 47, and then they start their perimenopause at 43. Very few women have any hormone difficulties prior to the age of 42 or 43. And in fertility practice, I can tell you that there seems to be almost a cliff at age 42. I can count the number of people that I helped get pregnant after age 42 who didn't use somebody else's eggs, because that's a whole different story, on the fingers of one hand after 42. Whereas there are a lot of people at 41 and 40 and 39 and whatever, but that's kind of where that all starts to happen. Now, hot flashes are still an enigma. We don't really know exactly what causes a hot flash. But we know that there is no really good treatment for hot flashes except for estrogen. Okay? And so if you want to get rid of hot flashes, you'll need to take some estrogen. You'll need to take enough to go from here to here. Now, if you're really overweight, you might not need to take much, and you might not have as many hot flashes, because we know that androgens, or male hormones made by the adrenal glands, can be converted to estrogens in the fat. So overweight women sometimes don't have as much trouble going through menopause in terms of hot flashes. That's not a universal rule, but it's the same. And in fact, if you look at the estrogen levels in an overweight woman, it's sort of like she's taking her hormones and just doesn't know it. She's got higher levels of hormones than she would be if she wasn't overweight. So that's another factor to consider. Anything that I gave you, and I told you that it would help your hot flashes, would help some of you. Do anybody know what percentage of you would be helped with your hot flashes if I gave you a placebo being a sugar pill or a fake pill? Do you know, any idea what the placebo effect is for hot flashes? It's almost 50%. Almost 50%. In control studies, where we take a whole group of women who don't know what they're getting, and we give half of them the placebo, and we give half of them the real thing, and half of the ones that are taking the placebo have relief. And then we need to make sure then that the real thing can beat 50%, because if it can't beat 50%, it's not any better than the placebo, right? So the relief of hot flashes with estrogen at normal doses is over 90%. There's really nothing else that's even close to that. But for those of you that cannot take estrogen, and there are a few of you that cannot take estrogen, if you've had breast cancer, we don't recommend that you take estrogen. Okay? If you've had a blood clot, we don't recommend that you take estrogen. There might be some exceptions to that. And maybe if you've had endometrial cancer, maybe you can, maybe you can't. That all depends. Okay? So what are you going to do? Maybe you're on tamoxifen, which causes hot flashes in and of itself. Well, the only other medications that have been shown to have an effect that's better than the placebo are some of the SSRIs, the selective serotonin reuptake inhibitors. Those are the drugs that people take for depression. Okay? And there are a number of them, and you need to check with your doctor to find out which are the best, because some of them don't beat the placebo, and some of them do. And the best ones, remember I said the placebo is 50%? The best ones will go to around 60 or 65%. Estrogen is over 90, but 60 to 65%. That's going to be of some help to some of you. So it's worth a try, as long as the side effects don't bother you too much. There are some side effects, but not terrible. So it's something to consider. Now, everything else that you can talk to me about, I don't care whether it's black cohosh or whether it's ginkgo biloba or whether it's anything else, when subjected to those kind of scientific trials where we give half the patients the placebo and half the patients the real thing, everything else flunks the test. So if you're taking anything else besides one of the SSRIs or estrogen for your hot flashes, you may be better because there's a placebo effect, but you're probably wasting your money. And you're subjecting yourself to the side effects of those other medications. In effect, you're conducting an experiment on yourself when you do that. If you think about it, you're conducting an experiment on yourself. Do you really want to experiment on yourself? Well, you can. It's okay, but you don't have to. So, how come those things are on the market? Well, in the 90s, the FDA decided that they wouldn't regulate those products the same as they do drugs. And so those drugs do not have to show that they're any good anymore. They just need to show that they're not harmful. And some of them can do that and some of them can't. So it's a gray area, and it isn't regulated very well. And as the old saying goes, caveat emptor. You know what that means? Let the buyer beware. So that's what I know about the effectiveness of estrogen to relieve hot flashes. Now, One other little complicating factor comes into this, and that is whether you still have your uterus or not. Because estrogen stimulates the lining of the uterus to thicken and grow. And normally, in a normal menstrual cycle, the level of estrogen is pretty low for a week, and then it's pretty high for a week, and then for 2 weeks, we have estrogen and progesterone. And progesterone is sort of like the brake pedal on the lining. It stops the growth. Estrogen is like the gas pedal. It's like pouring fuel on the fire. Progesterone is like putting water on the fire or putting on the brake pedal. In a normal woman, she has low levels of estrogen for 7 days, no progesterone, good levels of estrogen for 7 days, and then both for 2 weeks. That's her normal 28-day cycle. 1, 2, 3, 4 weeks. Okay? If you have a uterus and you take estrogen, even at this low dose and your hot flashes are gone, that's going to have fuel on the fire all the time with your uterus. And that will increase your risk of cancer of the endometrium, which is the lining of the uterus. That will increase your risk about 7 or 8 times, which is really unacceptable. Fortunately, there's a way to stop that, and that is to take progesterone. So if you take progesterone along with your estrogen, you can completely prevent the cancer of the uterus from happening. In fact, the rate of cancer of the uterus, listen closely, the rate of cancer of the uterus in women who take estrogen and progesterone, menopausal women, is actually lower than the rate of uterine cancer in women who don't take anything. So uterine cancer, endometrial cancer, is not a problem when you take estrogen and progesterone. So anybody that has a uterus needs to take estrogen and progesterone when it comes to taking hormone therapy. Now, how much progesterone do you need? Well, we know for sure that if you take progesterone every day, that will protect your uterus from endometrial cancer induced by the estrogen alone. We don't know for sure if you only take it 2 weeks out of the month. It may be that that actually doesn't protect you. And certainly if you only take it once every 2 or 3 months, that doesn't protect you. And if you take a progesterone cream on your skin, that doesn't protect you. Because remember I said that wasn't absorbed in a consistent way, okay? And vaginal progesterone probably does, but hard to say. Again, if you take a product that its strength is known, like Prometrium capsule can actually be used vaginally, that would probably do the job. But if you're taking a compounded progesterone, where you don't know for sure what the strength is from month to month and from dose to dose, that may not be enough. So again, I think the bottom line is that if you have a uterus, then you need to take progesterone, and the best way to take it is by pill and to take it every day. Okay? So that's the preliminaries. Now, you've heard all these things about how estrogen can cause breast cancer and it can cause this and cause that and can protect you from this and protect you from that and so forth. And I'll give you the bottom line to the whole story and then I'll fill in the blanks. The bottom line to the whole story is that if you need to take estrogen for hot flashes during this period of time that's going on here, and you need to take progesterone with it, the benefit to risk ratio, that is to say the benefits that you get versus the risks you get, are overwhelmingly positive, overwhelmingly good for 5 years. So for the first 5 years, you really don't have to worry about much of anything. The chances of that causing you any difficulty and giving you breast cancer or blood clots or all kinds of other things is really very, very low. And you will get, during that time, you will actually get some benefits in terms of less bone loss, protection against colon cancer, and some other things. Okay, so the first 5 years, if you're taking estrogen and progesterone, the first 5 years are pretty much a no-brainer. It's fine. Don't worry about it. Take it and put your hot flashes behind you for those 5 years. Okay? Now, if you're taking estrogen alone, without the progesterone, and the only reason you'd be taking estrogen alone would be if you've had your uterus removed, which means then you don't have that danger of the estrogen causing the cancer of the uterine lining, then you're good to go for about 10 years. About 10 years before there's any problems. And actually, it may be 10 years for the estrogen and progesterone as well, but I'm being conservative, and I'm saying 5 years is no question, and 10 is just fine if you're taking estrogen alone. After that, I don't know for sure. I don't know for sure because we don't have good data. Now let me tell you a little bit about what started all the controversy here, and that's the Women's Health Initiative study that you've heard so much about. It's an excellent study. It was done in a scientifically correct method, and the results are valid. The problem is the group of people that the study was done in. So let's suppose that we're trying to do this study, and let's say we have 10,000 women who are all 50 years old and all menopausal. And we're going to give half of them the placebo, and we're going to give half of them the hormones. And we're going to do this in what we call a double-blind method. That is to say, you're not going to know who gets what. You're not going to know if you're getting the placebo, or you're not going to know whether you're getting the hormone. And I'm not going to know whether you're getting the hormone when I take your history and determine whether you're having symptoms or not. Nobody's going to know who gets what until we're all done with the study, and then we're going to break the code and find out. Well, you couldn't do that study. Do you see why you couldn't do that study? Because if you took a whole group of 50-year-old women, they'd all be having hot flashes, or nearly all be having hot flashes, and the ones that were taking the estrogen would have relief of the hot flashes, and the others wouldn't, for the most part. And so everybody would know real fast who's who, and you wouldn't have a study that was scientifically correct anymore, so you couldn't do the study. So how would you do the study? Well, you'd pick a group of women who've quit having hot flashes. And you probably all know from talking to your relatives and friends and your grandmother and everybody else that hot flashes mostly stop at some point. Very few women have hot flashes all their life. There are a few that never go away, but most people stop. So if we took a group of women that were 60 and we studied them, we could do the study. We could, because nobody would know what's going on, and we could do the study. And that's what the Women's Health Initiative did. Most of the women were more than 60 years old. So what we did then, unfortunately, is we said we're going to study a group of 60-year-old women, and we're going to apply those results to women who are 45 or 50. That may not be a valid way to do. It'd be like if you did a study on men and decided you're going to apply that to women. That may not be fair. Or if you did a study on teenagers and decided you're going to apply that to 45-year-old women, that wouldn't be fair. And so that's the problem with the Women's Health Initiative. The Women's Health Initiative is a study of lots of women who were older, for the most part, particularly the ones that took estrogen and progesterone. And what that showed is that in those older women, the hormone therapy did not have a protective effect on heart disease, and it did increase the risk of breast cancer. Not greatly, but it did increase it. The absolute risk is something like 8 cases per 10,000 people every year. That's the additional risk that you would have if you took the hormones. 8 additional breast cancers for every 10,000 people that took it. That's what we call an absolute risk. Okay? So it's not high, but it's there. It's real, and nobody's going to argue that it's not significant. Because that's, if you put that in millions of women, that represents lots of cases. Interestingly enough, In the estrogen only arm, which was the women who'd had their uterus removed, and some of those women, for the most part, those are women who were often a little bit younger than the older women. In that group of women, the risk of breast cancer was actually reduced. Reduced. And so that has put us in a whole different frame of thinking, and that is we're thinking, well, maybe it's not estrogen that we need to worry about with breast cancer, it's more progesterone we need to worry about with breast cancer. And that's why we said for the estrogen and progesterone together, you were good for 5 years, and the estrogen alone, you were good for 10 years. Okay? So that's kind of where we are today as far as those things are concerned. The one thing we do know is that we're not giving estrogen and progesterone or estrogen alone anymore to try to prevent heart disease. We're not currently recommending that. We know that it will prevent osteoporosis. So if you're a high risk for osteoporosis, you might actually consider taking the estrogen for longer. Although there's some other treatments that can be used as well, and that's not something I'm going to talk about. So, a lot of things we know, some things we don't know, and that's kind of where we are today when it comes to hormone therapy and so forth. I'll take a few questions now, and I'll use those questions to kind of expand a little bit. Yes, ma'am.
Hi. I had a hysterectomy at the age of 28, and I was recently given blood tests and was told that I have hormone deficiency. I'm 62 years old. What good do hormones do me right now?
Well, of course you have hormone deficiencies. You're 62. Your ovaries have quit working. Okay. Okay, your question raises a couple of interesting things that I didn't talk about yet. Here's the first one. There is essentially, and I put it in your little handout, there's essentially no value in measuring hormone levels in women. The only women that need their hormone levels measured are some of my fertility patients who are getting those powerful fertility drugs, and I need to be able to know where I stand and how much to give and so forth. There's no evidence that measuring hormone levels in a woman at menopause is of any value at all. And I haven't ordered an estrogen level on a menopausal woman for years and years and years. Really, years and years and years. And particularly, I know on the internet, you can send in a sample of spit and they'll analyze your hormones. That is absolute baloney. Just baloney. The salivary levels of estrogen and progesterone vary so much from day to day and from person to person, and the laboratory tests that determine that are so variable that it means nothing. So the whole idea that you could send in a sample of spit and then somebody would formulate some perfect combination for you, I'll just say it again, it's just baloney. There's nothing to that. In fact, so you really shouldn't have had your hormone levels measured unless you're measuring some other hormone. There's a lot of different hormones. So because if we measured your hormone levels, they're going to be low, and all that matters really is, do you have symptoms? So if you don't have any hot flashes, it doesn't matter. You don't need to take anything. Okay? Now the other thing we did find out from the Women's Health Initiative is this, and the other thing that I need to talk about, and that is what we might call the window of opportunity. There's a reason why women have their heart attacks later than men. We know that. We know that women have their heart attacks starting about 10 years after the average man does. Okay? And we've thought for a long time that that's because of estrogen in those women. And estrogen does have a number of direct effects on vessels that are very favorable in preventing heart attacks. But at some point, the vessels seem to lose that. And so if you don't start the estrogen early, you come to a point where, like if you were to be given estrogen now at the age of, you said 62?
Yes.
Probably not going to make any difference as far as protecting you from heart disease if it's going to do that. There is some evidence that it would protect you if you were younger for that first 10 years. You will have fewer heart attacks if you take hormones for that first 10 years. You'll have fewer strokes. It'll be a better situation, okay? You'll live longer. But after 10 years and after you've been 10 years past menopause, then it may not work anymore. So that's the question that's still being answered. And there are studies going on now to see if that's really true or not. If you could start estrogen earlier, would it work better and would it continue to help women maybe into 15, 20 years or something like that, and you might gain enough protection against heart disease to offset the additional risk of breast cancer. Okay? Yes?
Is all of this to describe how we can do away with hot flashes? So if we just want to suck it up and go through the hot flashes, do we need to be taking anything?
No.
It's all to do away with the hot flashes.
Yeah, pretty much. Right. The main reason to take estrogen in those early menopause years is just to help you with hot flashes. Some women have real trouble with them and some women don't. Okay? Now you will get some of the other benefits. If you took a large number of women who were 50 and gave them nothing, and another large group of women who were 50 and you gave them something, and then you checked over the next 10 years, you'd find that there would be more people alive in this group over here. There'd be more deaths over there in the women that didn't take anything, and there'd be more heart attacks over there. Okay? Not a huge number, but there'd be more. So there is some protection. After 10 years, maybe there's not going to be much difference anymore, and that's kind of where we're at with that. When? Well, that depends. Okay? I'm going to conduct a quick poll here. Of the women in here who have had hot flashes, if those hot flashes lasted for less than 1 year and then they've gone away and you didn't take anything for it, so I want to know women who've had hot flashes and who took nothing. I want to know how many of you did the hot flashes last for less than 1 year? Raise your hands. A few. Okay. How many of you who had hot flashes and didn't take anything, how many of you did the hot flashes last 2 or 3 years and then went away? Okay, a few more. How many of you are still having hot flashes after 5 years? Okay, so that's an answer to your question. How many of you are still having hot flashes after 10 years? Okay, so do I have any way of predicting who will have hot flashes 10 years and who won't? Sorry, I don't know. I have no way to predict that. Yes?
I just asked the doctor. They said, ask the doctor out there, because I had my left tube and ovary removed, and I never had a hot flash. I had that done in August. Now I'm flashing all the time. Right now, I want to take off my clothes. But he told me, he said, ask the doctor out there. And I'm trying to say that. He said, oh, it'll go away, just don't take anything. And I'm coming in here, and now I'm saying, well, I should take something.
Well, you could.
Yeah.
I'm not saying you should, I'm saying you could.
Yeah.
You could take something for, you've had your uterus removed or just your
I
ovary?
have my left ovary and tube removed.
Okay.
Yes.
So you still have your uterus?
Yes.
Okay. Then you could take something for at least 5 years, and then you could see what happens after that.
And I take the estrogen
And progesterone.
Thank you.
Correct. And you had a question.
Is menopausal arthralgia a reality? I was diagnosed with menopausal arthralgia in the shoulder area, but never had hot flashes. I'm going into my 3rd year of menopause. But
I don't know of it. I don't know anything about that. I've not heard of that. I don't know anything about that. Yes.
I have a question. I mean, I understand about the hot flashes and that thing, and what you're saying to me is the truth. It varies in people, you know. But I have a question. They always say, you say by the time you get in your 60s, then things slow down. But there's another stage of menopause that I guess nobody talks about that somebody should tell people about.
Okay.
Tell us.
There's a commercial that plays all the time, and these women are saying, somebody should have told us. And they don't talk about it. the dryness and what happens to the woman's female organs. That's right. It is horrible,
Okay.
and nobody talks about it, and it is a part of going through menopause. And somebody should tell women. Somebody should at least sit down and say, okay, you think you had hot flashes and that was bad? Wait till this stage comes.
Okay. I'm glad you brought that up. I'm very comfortable talking about the birds and the bees with anybody. Okay? I've spent my whole life studying about the birds and the bees and all that sort of stuff. So that is a very real problem. And fortunately, there are some things you can do for that. Okay? You can take local estrogen in small doses that probably will not significantly increase your risk of breast cancer, and it will relieve those symptoms.
It's like putting lotion on dry skin.
Yes, you can do that. And there are several preparations. There's one that you don't even have to take progesterone with. Generally, if you put estrogen in your body, you're going to have to take progesterone if you have a uterus still. Okay. But there is one product that you can use where you probably don't need to take any progesterone, and that's a little ring. It's called the Estring, E-S-T-R-I-N-G. It's a little ring that you put in, and you leave it in there for 90 days. And then you don't have to worry about it.
Because I read about it, and the side effects it can cause toxic shock syndrome, breast cancer, uterus cancer. So, I mean, if you...
Well, that's just because the people who make that are CYOA. Okay. The truth is the risk of those things is very, very, very low. Okay, and it's not zero. Nothing you can do has a zero risk. Some of us could not make it home today on the freeway. I mean, but we're all going to drive. So I don't think you should really be too worried about that, to be honest with you. The benefit that you'll get compared to the risk that you'll have is not much. So any estrogen, whether you take it by mouth or whether you take it by patch, or whether you take it vaginally, any of those ways can help you with the vaginal atrophy and the vaginal dryness and make that more comfortable for you. Yes, you had a question.
You mentioned the SSRIs. Can you say which ones, and do they help mood and hot flashes? And how long should you take them? How do you get off of them?
Well, that's something that you'd want to check with your physician about as far as that goes. But there are studies that show their effectiveness compared to placebo, and there are a couple of them. I think Effexor, I think, is one that works a little better than placebo, if I'm not mistaken. There are a couple of them. I'd have to look that up to see specifically which ones. Some of them don't mix with tamoxifen very well, so there's a lot of different things in terms of choosing which one, but that's something that can be sorted out. I mean, if I had my references here, I could answer that question for you. Yes.
My doctor prescribed just progesterone. I'm a little younger and having a hard time getting pregnant, and I've got PMS symptoms. But taking just the progesterone made my symptoms even worse, so I stopped taking it. Should I have been taking something else as well, or is there something than just progesterone?
Yeah, progesterone alone for PMS kind of went out of style a long, long time ago. That doesn't really work very well. There are some better ways to treat PMS. The SSRIs, for one thing, are effective in PMS. Mm-hmm. And then if you want to get rid of your periods, if you're a reproductive age and you're not trying to get pregnant, if you're trying to get pregnant, yeah, well then that's a whole set. You've got a whole different set of issues that I'm probably not going to talk about in this room, but it's there. And my time is up, isn't it, already? Yeah. So I'll stay around a little bit. If you're interested, I'll answer any of the questions. But that's the end of our formal session. Thank you very much for coming.